Hello everybody, nice to see you again. Today's session will be session 25, middle or visceral compartment of mediastinum. Lesson 3 over 4 of mediastinum. Let's enjoy the chest radiographs with Dr. Y. I'm Dr. Y, the chest radiologist, medical professor in South Korea. Are you ready? Let's go! Now I think we are already very familiar with this diagram indicating the zone or visceral compartment of mediastinum. This blue-colored zone area as visceral compartment area of mediastinum. Please just forget the term middle mediastinum. We do not use that term anymore. We now use the term visceral compartment of mediastinum. In this axial CT image, the green line named as visceral paravertebral compartment boundary line is the posterior margin of visceral compartment, and this is the anterior margin of visceral compartment, pericardium. Yes, this blue zone is visceral compartment of mediastinum. Boundaries of visceral compartment of mediastinum as in posterior vertical line connecting a point on each thoracic vertebral body 1 cm posterior to its anterior margin. Let's see what's in there. The visceral compartment of mediastinum. A. Non-vascular structure. Number 1 is lymph nodes, trachea, carina, and esophagus. Vascular structures are from heart, ascending aorta, aortic arch, descending aorta, superior vena cava, pulmonary artery, and thoracic duct. Let's preview the pathologies of visceral compartment. A. Lymphadenopathy. This is the most common disease, such as lymph node metastasis, including small cell lung cancer, lymphoma, sarcoidosis, tuberculosis, lymphadenopathy, Castleman's disease. B. Non-vascular lesions, such as cysts, such as bronchogenic cyst, esophageal duplication cyst, and paraganglioma. The disease of large airways or esophagus, or about heart, aorta, superior vena cava, pulmonary artery, and thoracic ducts are too big to be dealt with in this mediastinal session. I'll introduce you later next session. For visceral compartment of mediastinal lesions on chest radiograph, we should focus on A. Focal contour abnormality of the mediastinum and widening of the mediastinum. B. Mediastinal lines. C. Hilum overlay sign. D. Silhouette sign. E. Mark band effect. Let's start the case. Case number 1. This is an old man's frontal chest radiograph. What do you see? What's wrong with this film? On the right side, this is 2 years before when he was okay, not abnormal. This is absolutely normal findings. Do you see something? Yes, right hilum. Suprahilar area, 2 cm SPN, solitary pulmonary nodule. Is that all? How about this azygous vein area, foveal lymph node area? Is there any difference with this one? Let's see this axial and coronal contrast enhanced CT images. This is lung cancer, right upper lobe 3 cm in AP diameter with foveal lymph node enlargement. Central low density with peripheral rim-like enhancement for lymph node enlargement. This is coronal view with central necrosis with enhancement of lymph node metastasis. For lymph node positive. Yes, this is lymph node metastasis from lung cancer. How about this old man's chest frontal radiograph? Large bulging mass, not obscuring pulmonary, descending pulmonary artery, hilum overlay sign, mediastinal based, another bulging mediastinal mass with right paratracheal stripe obliteration. Yes, mediastinum based large bulging lobulating mass. Let's see two axial contrast enhanced CT images. This is aortic arch brachiocephalic vein level. So this is 2R lymph adenopathy, large mass of lymph node metastasis or lymph node mass. Actually, this is a conglomerated lymphadenopathy of small cell lung cancer, heterogeneous enhancement. Look at this huge bulging contoured mass encasing large airway. This is conglomerated lymphadenopathy looking small cell lung cancer. What do we see with these two films? Yes, bilateral mediastinal bulging contour with widening of mediastinum, hilar enlargement, and right paratracheal stripe obliteration. In lateral film, this is a huge bulging contoured visceral compartment mass. Probable chance is lymph node disease, and both hilum is enlarged with lymph node, and there is pleural effusion in posterior costophrenic angle. How about these two axial contrast enhanced CT of upper side? Yes, huge conglomerated, relatively homogeneous mass with diffuse and mild enhancement encasing this brachiocephalic vein. We sometimes call this as sign of sandwich sign, and small pleural effusion and prevascular space, prevascular compartment lymphadenopathy, visceral compartment lymphadenopathy, and pleural effusion. This is the malignant lymphoma involving prevascular and visceral compartment of mediastinum. This is case number 4 of a young man's two chest radiographs. What do we see? Bilateral hilar enlargement. Bilateral hilar enlargement. What about the normal hilar structures? Yes, normal pulmonary arteries are obscurated. Obscuration, not clearly delineated. What this means? This mass density is in hilar location, bilateral hilar location of mass. And what about this? This is right paratracheal stripe obliteration with bulging contoured mediastinal mass. What about in this lateral film? Yes, all around at the hilar location, lobulating bulging contoured mass in young men. What is your guessing? Let's see these two axial and coronal contrast enhanced CT scan. What do we see? Prevascular lymph node, hilar lymph node, subcarinal lymph node, left hilar interlobar lymph node, relatively homogeneous, well-defined margin. How about the coronal scan? 2R, 4R lymph node enlargement, hyaline lymph node, subcarina, paraesophageal, left hilar and interlobar lymph node enlargement. This is a relatively typical place of sarcoidosis location. This is the sarcoidosis. How about these two films of middle-aged man? Somewhat similar with the previous case number 4, bilateral hilar enlargement and right paratracheal stripe obliteration or somewhat bulging contoured lesion in right paratracheal area. On this lateral film, there is a somewhat fullness. We call this as fullness of hilum. Something is filled, something is full here. Yes, what is this? What is your diagnosis? Let's watch closely with this axial and coronal contrast enhanced CAT scan. What do we see? Hilar lymph node, somewhat conglomerated. Subcarinal lymph node, somewhat conglomerated. But if we see closely, every lymph node has a central low density with rim enhancement about 1 centimeter in size. Every lymph node has central low density with rim enhancement. How about this coronal CT? 2R, 4R paratracheal lymph node enlargement with central low density and well-defined rim enhancement. Also in left supraclavicular area, 1L lymph node. Actually, these low-density areas causation necrosis of tuberculous lymph node. What do we see with this young man's chest radiograph frontal projection? About 4 cm sized, well-defined, mediastinally broad-based mass is here, clear margined. Right paravertebral stripe is okay, and right pulmonary arteries looks okay, not obscured. What is this? On this axial contrast enhanced CT, we see 4 cm thin, 1 mm thickness, uniform thickness cyst with homogeneous fluid, slightly high density fluid at subcarinal area. That's why the right paravertebral stripe was okay, right hilar pulmonary artery was not obscured. This is relatively typical location of a bronchogenic cyst, subcarinal area. Bronchogenic cyst as congenital foregut malformation, usually well-defined mass, homogeneous density of fluid, up to 90%. They are located in visceral mediastinal compartment, most commonly in subcarinal area and next right paratracheal area and very rarely intrapulmonary location. This is case number 7. This is lower esophagus. On its right side, there is a 3 cm well-defined, very thin walled, homogeneous fluid-filled cyst. This is aorta, hemiagual vein, agual vein, and inferior vena cava. Regrettably, we don't have chest radiograph of this young man. This is a relatively typical case of esophageal duplication cyst. This cyst is very rare and one of the congenital foregut malformation, usually showing well circumscribed cystic mass near esophagus, usually lower paraesophageal location. Case number 8. This middle-aged woman shows no abnormality on chest radiograph, but she complains of dysphagia and a mild fever. There is some focal bulging on right side of trachea. I'm not sure this is the positive finding or not. On her axial and coronal contrast-enhanced CT, there is a focal area of gas and small, somewhat pus-like density on the right part trachea location. On this coronal setting, it is about 3 cm in length with dirty-looking air and some necrotic material on right part trachea area. This was acute mediastinitis. Actually, she doesn't know why this was happened. Let's review about acute mediastinitis. It's a relatively severe disease. Sometimes it can be fatal. It occurs after traumatic iatrogenic damage to esophagus or airways, or after complication of cardiothoracic surgery. Sometimes it can be from the neck. Descending infection from the neck can cause acute mediastinitis. In this case, this is severe and sometimes can be fatal. These are the 2 chest radiographs of a young man who was very ill-looking with painful chest pain on the left side. We see many gases on the muscle side. This is subcutaneous emphysema, and even we see the gas along the trachea. Both sides of trachea, we see the pneumomediastinum, and we even see the outer walls of both main bronchi contrasted with air and the mediastinum. On his left side, there is a dirty-looking exudate or hematoma on left side, not transudate. On his left side, left lateral filum, there is an exudate or dirty fluid on left side. And we see the gas in front of the trachea and along the outer wall of left main bronchus. On this axial and coronal contrast CT, we see the distal esophageal tear with the dirty pleural fluid here, maybe food contents, blood, or pleural effusion. On this left side, the distal esophagus wall is not intact, and there are fluid and dirty fluid and pneumomediastinum here. This is the famous Boer-Haber syndrome, spontaneous distal esophageal rupture, usually on the left side, and it is very, very fatal. Rapid surgery is necessary. Case number 10. This old man had a traffic accident. We can see many rib fractures on the left side with dirty pleural fluid, probably hematoma. And his systolic blood pressure is going down and down. On these 2 axial and coronal contrast enhanced CAT scan, you can see the aortic arch and aortic rupture here, extravasated contrast media here, with hematoma in the mediastinum, with mediastinal widening, with pleural hematoma, with gas in the muscle. In the coronal CT, mediastinum is filled with hematoma, and we see the direct leakage of the contrast media from the aortic arch here. This is aortic rupture here, and this is hematoma with multiple left rib fracture. Case number 11. What do we see with this middle-aged man's chest radiograph? Yes, there is a bulging contoured mass here, retrocardiac, and obliterating aortic line. That means this mass is mediastinal but obliterating in contact with the aorta, para-aortic lesion. Yes, we see the normal paraspinal stripe. This means this pathology is not in paravertebral compartment location. This is para-aortic lesion. What is this? This axial CT image explains everything about the chest radiographic findings. This is para-esophageal varix, encircling the distal descending thoracic aorta on the left side, not in the right side. Yes, these are all varix veins. That's why the aorta line was obliterated. That's why the paraspinal stripe was okay. Paraspinal stripe is okay, not in paravertebral compartment lesion, but in visceral compartment lesion. This is paraesophageal varix of liver cirrhosis patient. And this is case number 12, actually a quiz for you. This is a young man's chest radiograph. What do we see? And you can diagnose what is this. You can see the bilateral mediastinal widening and diffuse bulging contour at the mediastinum, well defined. Tracheal stripe obliteration here on left side too. And what do we see? Yes, large amount of left pleural effusion, right side pleural effusion. Please look at this axial contrast enhanced CT of upper portion. This is aortic arch, left brachiocephalic vein. Yes, prevascular compartment. There is a conglomerated mass, conglomerated lymph node, and actually two are lymph node enlargement on this visceral compartment. There is also another lymphadenopathy. What is this on right axilla? Lymphadenopathy. What are these on left axilla? Lymphadenopathy with left pleural effusion, large amount of left pleural effusion. What is your diagnosis involving prevascular compartment and visceral compartment at the same time with the shape of conglomerated lymphadenopathy? Yes, this is malignant lymphoma, correct. Now, session 25 is over. How do you feel now? Are you happy? Are you in excitement? I applaud your hard work. Thank you so much for your hard work. Like, subscribe will be a big support to Dr. Y. Thank you very much. Have a good night.